So welcome back, clinical problem solvers. I'm pleased to have everybody here in this room today. It's a big day for us that we are receiving the internal medicine residency program of Allegheny, and we have we have the PD, the chiefs, and the residents. We have the people that will help us with the session, and I will begin with the introductions. So we have Ethan that is helping us with the teaching points. Ethan, can you say hi for us and see how life's treating you?
Hi everyone, my name's Evan. I'll be doing teaching points today. Doing really good. I'm a third year medical student, currently doing inpatient pediatrics. I'm just having a blast going through rotations. Nice to see you all excited for this case here.
Great. Well, and Iron is helping us with the scribing. How have you been?
Hey everyone, I'm Aaron. I'm a medical graduate from the Philippines, but I'm based here in New Jersey. Currently, I'm doing an outpatient cardiology rotation, and that's been fun. So yeah, excited for your case.
That's great. And we have all our case discussions. Dr. Jeffrey Shen, a huge piece and legend of our group. Hey, Dr. Shen, how have you been?
Good. Hey, thanks for having me. I'm Jeffrey. I'm one of the rheumatologists at Duke, and I've been very excited to be part of Clinical Problem Solvers and excited for this invitation.
Yeah, and the only one, Zachariah, is a huge piece of our academy member. Also, he is from South Africa. And please, Zachariah, introduce yourself.
Hi everyone, I'm Zachariah G, currently in South Africa, and very excited for this case. Jeffrey said yesterday he'd need my help, but I honestly think that I'll just be helping show to everyone how much expertise and time is required to become somebody like Jeffrey, who's a very special rheumatologist. So excited to learn.
And before I have the pleasure to introduce everybody for Allegheny. I am Vini. Um, I am just graduated in Brazil, and I'll be facilitating the session today. So we have the case presenters, Vani and Melina and Alexis will be presenting the case for us, and we'll also be discussing alongside Taz, Rachel, and Abby. So I think that we are all set. Um, we can we can share the screen, please, even. And then when you guys are presenting like the first aliquot and of the case, I believe that is a good moment also to introduce yourself, so we can start.
Hi, everyone. I'm Bonnie. I'm a second year internal medicine resident at Allegheny General Hospital. I'm so excited to be here today and to represent my program a little bit, which is a great program, and I loved my program. So I'm excited to talk to you about this very interesting case. Okay, let's get started. To start with a bit of a one-liner, we are going to talk about today an 89-year-old female with dementia who presents with worsening fatigue and shortness of breath for the last few months after a mechanical fall at home.
Jeffrey, would you like to start?
Actually, why don't you go first, then I'll take it after, if that's okay.
Absolutely. Well, thanks for this really interesting first aliquot. And I think the first thing to remember is that we have an elderly patient and somebody who is already known with dementia. And that's going to change things a lot in terms of unless there's a reliable caregiver, you're not going to be able to get the history we might want. And potentially certain tests that might not be useful if somebody can tell you, for example, if somebody tells you they have a fever and a cough and shortness of breath, they're inflamed and that you have a good pretest probability of pneumonia, and a CRP might not even be a test that you might need to order. But in somebody who you're not able to get that history from, some lab tests will become valuable. But I think what's interesting is that we have a relatively subacute to chronic time course of somebody with both worsening fatigue and shortness of breath. And I translate that into either there's something in the blood, like a deficiency of a molecule like hemoglobin, or there's something wrong with the cardiovascular apparatus or the pulmonary system. And I think it would be very interesting, as recently learned on the academy, that the presence of whether the patient's actually hypoxic at rest or becomes hypoxic with exertion really will tell you whether there's something more likely to be wrong with the lungs, or is it something really with the cardiovascular apparatus, as subacute to chronic presentations of pulmonary diseases usually will have, when they are this severe, will have hypoxia at rest. But often cardiovascular diseases like heart failure with reduced ejection fraction, unless you walk the patient, you might not necessarily see them becoming short of breath with hypoxia. So I think it'd be very interesting to find out the past medical history and if there is a reliable caregiver to provide any more details at all. Yeah, but I'm interested to see what else you can add to that, Jeffrey, especially with regards to the fall.
Yeah, I totally agree with what you're saying. Right, I mean, right now, we have a limited amount of information of which to focus. And one of the important things is to realize that while we are focusing on this information, it may end up not being the most important area of focus eventually as we get the history. So initially, because we're getting this information, I would be focusing on cardiopulmonary causes because those are by far the most common causes of fatigue and shortness of breath in this type of presentation. So in the history, I'd be asking questions like to make sure that I understand, is this shortness of breath seem to be coming from a cardiopulmonary source? At the same time, I'd be trying to create the context because the context can really, really shift how we think next about the patient and what we focus on. So for example, if we realize that she has a history of cancer or she has a history of a recent blood clot, like all of these important things that we know from her HPI and past medical history will influence how we think about her next. And yeah, excited to hear more.
We are ready for the final aliquot. Second
Okay.
one, sorry.
Oh, yes, of course. So moving on to the second aliquot, hopefully with this aliquot, I'm able to give you a little bit more context and fill in some of the gaps and answer some of the questions that were brought up earlier. But this patient basically lives at home, and she lives on the second story with her daughter. She fell down 12 stairs, but during her fall, it was thought to be largely mechanical. No observed loss of consciousness. She did hit her head, scraped her elbows, and then she presented to the ED as a trauma alert. When she presented, she was very confused, A&O times 0, but luckily her daughter was bedside, able to provide more history. She did notice that the patient has been a little bit more fatigued, a little bit more short of breath over the last few months. This breathing trouble seems to be somewhat related to movement, but they're not really able to identify a clear pattern. They note that during some of these episodes where she's feeling short of breath, her oxygen saturation drops to the 70s to 80s. But they're able to quickly get it back up after putting her back on 2 liters for 1 to 2 hours. The patient is able to ambulate independently, but she does require some assistance with activities of daily living, such as finances, cooking, cleaning, because of her progressively worsening dementia. In terms of any recent illnesses, she hasn't had any recent fevers, chills, no dizziness, no lightheadedness, no chest pain. So this is really how she presented to us in the hospital.
All right, that's great. And that's the end of the aliquots?
Yes, that's the end of the second aliquot.
Yeah, do you want to start, Cedric?
Yeah, absolutely. So I think the first thing is just, again, with an elderly patient, the chances of her having more than one diagnosis, really, really quite high. And it's in real life, patients that are elderly get multiple different presenting issues because of the combined effects of multiple comorbidities at the same time. And I think here, just with regards to this fall, the first thing is we have a bit of a history that this patient's been having some pre-existing cardiovascular compromise. And I'm just wondering if was this fall potentially triggered by a worsening of that. So for example, somebody at this age gets aortic stenosis and eventually gets to a severity level where they syncopize, or is it that the entirety of a presenting issue is not related to a pre-existing cardiovascular compromise and that the consequences of the fall, for example, her having potentially a major subdural bleed could be the reason that she's now confused and so on. So I think here I'd really want to immediately get a basic metabolic panel, know what the sugar is, and an ECG would be really, really quite telling, and then go from there. If we were to go a little bit further into falls, again, in the elderly, patients who get falls it's usually multiple different things that sort of combine to make you at more risk for fall. So it's a little bit of diabetes causing some proprioceptive issues, a little bit of coordination issues as well, and then a little bit of weakness now for potentially something like a stroke in somebody who already has osteoarthritis and some sort of lumbosacral neuropathy that all just sort of combine together to result in a fall. It's quite unusual for a young patient to just fall on their own, but in an old patient, I again think there's going to be multiple different things that led to her falling. And I'm just wondering if this entirety of the presenting issue now in the hospital, is it a consequence of the fall, or is there something that existed before the fall that led to her coming in?
Yeah, I think I'm right there with you, and I'm trying to understand the patient and the context a little bit better. Right now, we do have some evidence that we potentially may have problems in the cardiopulmonary system that is leading at least to the shortness of breath. And I'm not yet sure what to make of the fall. I think what will be really helpful after we understand the past medical history, the medicines, those kinds of histories of that will help us tease apart whether the fall is something that's already explained, like this is just a mechanical fall, as they said, she tripped, or do we need to worry about an emergent pathology that is occurring, such as a brain bleed or something like that? But before I get there, I think, if I were to get this patient and I don't have much that I know about them, I would be doing a really broad workup. I would do a very thorough physical exam, definitely getting a CBC, CMP, a lot of imaging. And then I would think about this patient in two different ways. One, as Zachariah was saying, like, what are the common things that can cause all these symptoms, right? For example, does she have diabetes? Does she have hypertension? And now that's leading to problems with like heart failure because she's had hypertension for many, many, many years. And then what are the life-threatening causes that we need to make sure? So going through like life-threatening cardiopulmonary causes first, but then as the workup comes back, still considering that. That's how I would approach this patient next. But excited to hear what happens.
Okay, I will then move on to aliquot 3 and hopefully give a little bit more information. I know we have a lot of really great differentials already, so hopefully this information is able to help us narrow it down a little bit more. But aliquot 3, so this patient has a past medical history of dementia, low-grade B-cell lymphoma, not on any treatment, just surveilling for right now. History of PFO with the right to left intracardiac shunt, which was noted 2 years prior on TTE. Hypertension, which is very well controlled at baseline. Family history was not significant. Social history, no history of tobacco or substance use, very rare social alcohol use. She drinks maximum of two drinks a week, and she wasn't drinking the day she came into the hospital. And she lives with her daughter, as I told you guys before. In terms of her medication, we rightfully brought up that there's a lot of different things that could be contributing, especially to an elderly patient, but she has not had any recent changes in her medication history. She's only on vitamin D, vitamin B12, and lisinopril and donepezil, and all of the dosages as well as these medications have been chronic outpatient medications, no over-the-counter medications for her recently. In terms of physical exam, when she presented to the hospital, she was afebrile, heart rate was 85, respiratory rate was 16. Her blood pressure was quite high, systolics of 200, diastolics of 100, and she was saturating well on room air on presentation. Apart from that, physical exam wise, she wasn't really in too much acute distress. She was quite banged up, had a left scalp laceration, had some bruising on her bilateral elbows, but she did not have any lower extremity edema. Cardiovascular exam, pulmonary exam, and abdominal exam were largely normal. Neurologically, as per her exam, she was alert and oriented times 1. Her it was fluctuating. She was able to respond fluently, but most of her answers were nonsensical. Her cranial nerve exam was largely intact. She did follow commands in all 4 extremities, did have full strength throughout, and full sensation throughout. So that's where I'm going to end aliquot 3.
Oh, okay. Well, I think that's a really, really interesting past medical history. And I think just to start off with the baseline, the fact that she has hypertension, I'm not surprised at this age. And I do wonder with that extremely widened pulse pressure, is there the possibility that she could have aortic sclerosis and have sort of isolated systolic hypertension? Or is that something where you need to break out your whole schema for high output cardiac states? And I'm not really seeing anything. She's not tachycardic, although mind you, at this age, the chance of her having some degree of sinus node dysfunction is possible. So she could be relatively tachycardic or just not able to mount that response. And I think this, with regards to the past medical history, I'd have to check on how a low-grade B-cell lymphoma usually present. Can it have a phase where it becomes more inflammatory and potentially go into leukemic phase, or is it usually one of those indolent lymphomas that elderly patients can often tend to live with without necessarily getting consequences from? I think in this case, there's a decent chance that she could be having some sort of consequences, especially with her other past medical comorbidities. And the PFO I find interesting, and I do wonder, an elderly patient now not feeling well that has fallen, gets known with the PFO, is there a possibility that she could have had some sort of paradoxical emboli? And already I was thinking about a CT brain before we even knew about the PFO, as she's had quite a major fall at that age. And I think this just makes me really, really want to make sure that she hasn't had some sort of ischemic event. Yeah, so I think that's where I'm at, and eager to see what Jeffrey has to add.
Yeah, no, amazing. Right along there with you. Still thinking about, just as you said, CT head, making sure that she doesn't have a brain bleed. So making sure we investigate the life-threatening causes. And then I guess I'll comment a little bit about what to focus on. So we have, a very complicated situation in terms of when we talk about in clinical problem solvers, when you have a case that has a lot of different aspects, how do you determine what to focus on? What do you think is signal and what is noise? And I think sometimes that can be really challenging, but I would probably say that right now, what jumps out to me, my instinct is the low oxygen of dropping to 70 to 80%. And the reason for that is because one of the major complaints she has is shortness of breath and fatigue. And that is an objective marker that we can say we have true evidence that there is hypoxemia that is occurring. So that will be one of my major focuses. How do I understand this problem better? So we were told in the HPI that this problem of the hypoxemia dropping to 70% improves pretty rapidly with a minimal amount of oxygen. I might be overinterpreting this, of course, but now because I'm focusing on this, I'm going to guess that that could represent hypoxemia with a normal AA gradient, which essentially means that what I would be worried about are causes of hypoventilation. So the next things that I'm going to be worrying about are what could be causing hypoventilation in such a patient, right? So the things that usually cause hypoventilation, there are a couple of different factors. So what is needed for you to be able to ventilate or get rid of the carbon dioxide in the body? The first is, of course, we think of initially as the structure of the lungs. So the lungs have to be working appropriately so that there's not too much air trapping there. So if this patient has COPD, smoking emphysema, that is a common cause we think of hypoventilation. The other things are then, of course, the lungs have to work, but the physical act of ventilating requires an intact neuromuscular anatomy. So the things that can limit that are weakness in the nerves or muscles. And also one thing that can limit it is sometimes body habitus. And then we can even think about rare anatomical limitations. Like I'm not aware if the patient did have like rib fractures or something like that, could that also cause hypoventilation because of the pain? But we're not really getting the history of that here. And the last thing is for you to even have this process, right? We are not every day thinking about, hey, I should breathe in, I should breathe out, breathe in, breathe out. And the reason is because this is innate. This is innately known to our brain. This is a reflex that we always do. So if you have a problem in the central nervous system as well, which again goes back to the neuroimaging that we need, that could also be a dangerous area of hypoventilation. So the things that you would think about from a central nervous system aspect are imaging positive, which we would think about all the things in structure that could cause that. And then also we want to not forget that things that come into the body from the outside, such as like opioid overdose, something like that, can also cause hypoventilation. So that's where I'm focusing now as I do the workup. I'm excited to hear more.
Okay, so aliquot 4 gives us a little bit more objective data that you both were looking for. So we do have our lab tests. Our BMP did show pretty normal electrolytes. The BUN had slightly bumped to 24. Creatinine was 0.83. Glucose was slightly elevated at 102. Calcium was slightly low at 8.3. In terms of our CBC, we have slightly low hemoglobin at 11.3 and MCV at 95.4, but otherwise was pretty unremarkable. Urine analysis did show some trace blood, 6 to 10 RBCs, no WBCs, no leukocyte esterase, no bacteria, no protein. Cardiac profile did show a pro-BNP of 275 and troponins, which were flat at 11. We did get that CT head, and that CT head did show a large left parietal scalp lesion as well as a trace left occipital horn intraventricular hemorrhage. Trauma scans otherwise, including the CT cervical, thoracic, and lumbar spine, was largely unremarkable for any acute fractures. We got a CT chest, abdomen, pelvis with contrast in the ED, which showed diffuse lymphadenopathy through the neck, chest, abdomen, and pelvis, which was consistent and stable with her lymphoma history. Some pulmonary edema, as well as no pulmonary embolism, which was identified on this scan. Chest x-ray was remarkable for some increased right basal patchy opacity, concerning for some either pneumonitis or aspiration pneumonia. EKG was unremarkable for any acute or any ST changes, and it was normal sinus rhythm. So that is where I will leave you with aliquot 4.
Gosh. Okay, so I think the first thing is I have to be honest, just getting all of that data and going through it, there are many things that are slightly abnormal, but I'm trying to sort of find anything in that well, all of those findings that felt like a pivot point where we might be able to go down and find the answer to this case in there. And I'm really struggling at this moment. But if we were to work through it systematically, I think the first thing is this patient has anemia, and it would be good to know a baseline. I heard that she's having a parietal bleed, and this would be something I'd Google about what are the places where you can bleed so heavily in the brain that you can have and actually have an acute drop in your anemia. But if that's unlikely to be the cause, then I'd be going down the same old schema of getting the full blood studies with iron studies, B12, folate, and then getting a smear as well. I do wonder, with the patient having a history of a low-grade B-cell lymphoma, could this potentially now herald some bone marrow involvement with a possible MDS or just involvement of the lymphoma into the bone marrow? As we heard that the imaging has been stable in terms of her diffuse lymphadenopathy elsewhere, but that doesn't necessarily mean you can't have progression of disease with a bone marrow mets. And then I think the one other thing is it would be good to know and find out, how did this patient's B-cell lymphoma, how was it diagnosed? And is it possible that the lymphoma was potentially an incorrect diagnosis, or just one part of the patient's hematological pathology, and that she has something else going on now? And I think that diffuse lymphadenopathy, it would be good to go through the systemic approach and checking does she have any hepatosplenomegaly as well. But I translate that basically into the patient having reticuloendothelial activation, either most likely of some sort of infectious cause, but with her history of potentially having a malignant cause. I don't usually think of many autoimmune diseases causing this degree of lymphadenopathy, but certainly sarcoid could do something like this, and certainly SLE can cause diffuse lymphadenopathy, but I'm just not sure how common that is in comparison to something like the lymphoma that's in the past medical history.
Yeah, this is an interesting development. And I think we're still trying to figure out like what is the important thing to focus on. You know, we have this diffuse lymphadenopathy, but we've been told that they have low-grade lymphoma. So usually low-grade B-cell lymphoma is pretty inactive and doesn't necessarily require treatment. So often the case is you can have CLL or follicular lymphoma, and yeah, of course, you know, I don't understand this fully, but oftentimes what I see is that hematologists will just clinically monitor these patients and not necessarily start them on anything. So is the diffuse lymphadenopathy here, is this signal to what the problem actually is, or is this just noise because it's just this this low-grade lymphoma that we have in the background that we know from the history? And then the other thing as well that I'm trying to understand really is, again, focusing back onto the hypoxemia, we have some evidence now of pulmonary pathology. There is a right basal patchy opacity on a chest X-ray. And that, you know, essentially is some evidence of what could be causing hypoxemia. What I would usually expect with that is if that were to be the case, then my previous thought analysis of the hypoventilation may not necessarily be correct. But I still want to confirm that. So in this scenario, I would still, you know, get a VBG just to make sure that the hypoventilation is not also co-occurring. Because as Zachariah said, you know, in patients like this who have dementia, complex history, hard to get a good history from the patient themselves. Multiple things can be going on at the same time. So I'd be kind of working it up in two different ways. One, investigating what is this opacity? You know, is this an infection like pneumonia? And probably what I would say is empirically, while we're waiting for that to be figured out, I may start this patient on antibiotics to cover for causes of community-acquired pneumonia, while trying to understand better what that opacity is from. If I wanted to try to connect the dots here, I'm not really seeing an easy way to connect the different imaging findings. We have a scalp lesion from the hematoma there. I don't think that's necessarily related to diffuse lymphadenopathy or to the opacity that they're having. And in addition, if the diffuse lymphadenopathy is from lymphoma, I'm also not really seeing that that's actually something that usually presents as an opacity when on a chest X-ray. So usually when lymphomas, if they were to become higher grade and involve the lungs, you would see either multiple consolidations that would be considered concerning for metastasis, or it would look like an interstitial picture, like a diffuse lymphomatosis pattern, which can be sometimes seen in specific subtypes like lymphomatoid granulomatosis. So I think I would be heading towards like a CT chest next, and getting the rest of the labs, getting a VBG. But I'm very curious to see what happens next.
Awesome. So hopefully with Aliquot 5, we're able to get rid of some of the noise and get to the big thing that kept her in the hospital. But so this patient in the ED was evaluated by neurosurgery for this left occipital horn interventricular hemorrhage. Neurosurgery saw her, said there's no neurosurgical intervention needed, and that she was stable for a floor admission, and they would just follow up with the CT. Trauma surgery evaluated her also when she was at the ED, repaired her scalp laceration. But then the patient, while in the ED, unexpectedly desaturated. So just to remind everybody, when she came in, she was saturating well on room air. But the patient unexpectedly desaturated, required initially 15 liters of oxygen, started to desaturate on 15 liters of oxygen, and then started to require more oxygen and was put in on heated high flow nasal cannula. and then was admitted to medicine for further workup of this hypoxia. At this time, we got a repeat chest x-ray with a sudden desaturation, which did not show any change from the previous chest x-ray, which was obtained in the ED. So at this time, the patient was admitted to medicine for further workup, diagnosis, and treatment of this new hypoxia. And that is the end of aliquot 5.
Gosh, well, a very scary situation. And I think I first have to say that the fact that this happened so suddenly makes me really worried that something else has happened in addition to what the patient's already pre-existing baseline compromise. We already know that there was something relatively severe going on because before even this was happening, she was suddenly desaturating to the 70s in the 80s. And the fact that it is possible that whatever was causing that has just worsened, but the sudden desaturation makes me wonder, could she have suddenly aspirated, potentially secondary to a seizure? I'd have a low threshold to consider getting repeat brain imaging, and definitely the lack of any change on X-ray to me doesn't necessarily rule out an acute aspiration pneumonitis, as it may take a little bit of time to develop. In addition to that, the one other thing is the initial CTPA ruled out a PE, but somebody who definitely is at risk for having a venous thromboembolism suddenly desaturating like this would make me wonder, could she potentially have a clot in her lungs as well? And I think I'd want to rule out those sudden acute causes of hypoxia, and in tandem starting to try and investigate further why she's been hypoxemic or before all this happened, and is there something that suddenly just worsened that's related exactly to the disease process going on?
Yeah, I'm very worried, very worried about this patient given this acute desaturation. And it's super helpful to know that there's, at least at this point, no change in the chest x-ray. I think again, so this is leading me to think that maybe my original focus on the shortness of breath and hypoxemia could be a correct focus of the signal. And I'm beginning to wonder again, are we in the scenario of which we're missing a cause of hypoventilation? But what could cause like such a severe change in hypoventilation? I think that's a little bit more confusing to me. The other part of that, I guess I've just noticed is that there is also this small intraventricular hemorrhage that was on the CT scan. I mean, I would think that if it was a small hemorrhage, that wouldn't be really a great cause to say that this is the cause for hypoventilation. And of course, we also have this history that neurosurgery evaluated the patient and thought they were stable. I guess what I'm worried about is it possible that now, because of this acute change, the bleed has gotten a lot larger, and now we have a large intraventricular hemorrhage, and that maybe is causing something like hydrocephalus? Because then what I'm realizing with this patient is they have dementia. So if you have a CNS cause of hypoventilation or CNS cause of hypoxemia, you're not going to be able to easily get a history because the patient already has baseline neuropsychiatric dysfunction or neurocognitive dysfunction. So that could be a place where there could be an acute change there, but we're not able to notice necessarily the acute change because usually you would see it more abruptly as altered mental status, loss of consciousness, but if the patient already has severe baseline dementia, you may not see a change there, and that actually could be the source. So that's one of the things that I'm worried about. I'm not seeing a way yet as to how you can get an acute onset of neuromuscular weakness. The other thing that can be really fast and can be co-occurring at this time is that we have a second hit. For example, the patient now has a pulmonary embolism while they're in the hospital, and that's why we have a new drop there. And so I would be kind of working up these two scenarios and still trying to figure out if we can get a blood gas at this point. But excited to hear what happens next.
Can I just add one thing, because I saw Austin mentioned something in the chat that's I think actually the major pivot point. is that the patient actually becomes more short of breath when she sits up, and it actually improves while lying flat. And that is very interesting, as it's basically the patient has the opposite of orthopnea. And the syndrome that I honestly don't fully understand too well is called a platypnea orthodeoxia syndrome. And my limited knowledge around it just knows that it's to do with some sort of shunt, whether it be intracardiac or potentially something more esoteric like hepatopulmonary syndrome with some disease from below. And from my understanding, in addition to the shunt, you often have something structural as well that together with the shunt contributes to this fascinating presenting symptom. But it's not something I'm very familiar with. Besides.
Yeah, awesome. Vani, why don't you tell us what happens next?
Okay, awesome. So this patient was noted to be more short of breath when agitated, and when she was, and it seemed to improve, in fact, when the patient was lying down. She was, like you said, Dr. Shen, started on empiric treatment for pneumonia. The pneumonia workup, however, was largely negative. Procal was 0.05. There was no leukocytosis. Pulmonology and cardiology were brought on board. Pulmonology said, let's avoid BiPAP to avoid worsening of the shunt, and maintain a strict oxygen goal to avoid pulmonary arterial hypoxic vasoconstriction, and put her on a pulmonary toilet regimen. Cardiology said just to treat the pulmonary edema with IV diuresis, and they recommended a repeat TTE with bubble. However, this was not pursued because, as per the patient and her family, their goals of care shifted, and they wanted to take her home and focus on comfort-only measures. They told us to keep her head of bed elevated at 10 to 15 degrees, and avoid keeping her upright, as this would worsen the shunt. And at this point, the diagnosis was made of acute hypoxic respiratory failure, with severe right to left shunting, as you mentioned, causing platypnea orthodeoxia syndrome, likely secondary to flash pulmonary edema, as well as aspiration pneumonia. So when she presented, she had those very high blood pressures, and we also saw those opacities on chest x-ray. So this intrathoracic pressure was increasing her pulmonary venous pressure, and was really increasing the shunting from the right to left as well. In terms of the patient and how she ended up doing, when she was discharged after diuresis and antibiotics, keeping her positionally in the head of the bed elevated with 10 to 15 degrees in a supine position really did truly improve her oxygenation status, and we were able to bring her back to room air. And that is generally the end of this case. I did also look into platypnea orthodeoxia syndrome a little bit too, because I was really interested in the physiology and how this ends up happening. Why is it positional? Because usually when we think of positional, we think of heart failure, and we think that, you know, you're more likely to have more shortness of breath lying down. But while I looked into this, it looked like it was mostly caused by the fact that when you're upright, the IVC shunts, the way it's directed, it pushes blood towards the PFO or the ASD, and that is what increases the shunting overall. So that was a physiological basis. And of course, other causes, like you mentioned, could be hepatopulmonary syndrome, or AV malformations. And in those causes, when you're standing up straight, there tends to be increased blood flow to the lower lobes of the lungs as per gravity, and that also increases shunting where most of the AVMs are. So we thought this was a really interesting case. Thank you so much for giving me the opportunity to present it. And thank you so much. I feel like we already covered most of the diagnoses. I was writing them down as we were going, and I realized we already named pneumonia. We already named flash pulmonary edema in the chat. We already named PFO and brain bleed before I even gave those objective data. So I feel like we actually already covered everything that I just ended up giving the data for. So thank you so much.
Well, Vani, phenomenal case and pristine presentation. Yeah, just outstanding. I'm curious if Jeffrey and Zachariah have any final comments or just anything that you guys want to share.
I think just the one thing for me that I find interesting is this patient's presentation of flash pulmonary edema. The other term, sympathetic crashing acute pulmonary edema, I usually associate it with patients being a lot more short of breath, very tachycardic. And I just wonder in this almost 90-year-old woman if she potentially had some degree of sinus node dysfunction that would not allow her to mount a tachycardic response. Or did that potentially happen later on when her positioning changed and the pulmonary edema started to worsen with hypoxia?
Yeah, amazing case. Thanks so much. I realize now that we had focused initially correctly on the shortness of breath, but I missed the key point with the movement being a really key issue here, and I had not considered this really rare and very specific syndrome. But again, I'm very impressed that because Zachariah mentioned in the very beginning, this could be multiple things going on at the same time, which is what ended up happening. We have 3 diagnoses going on at the same time. So always important to keep in mind that you can have multiple concurrent conditions. So thank you so much, Vani.
Yeah, absolutely. And before we moving on, I just wanted to take time and thank Evan for the teaching points. And now I believe that we can move to the Q&A session. And I would be pleased if the chiefs, Abby and Richard, take the time to present yourselves, please. And then we can move with a word from that.
Go ahead.
Oh,
We just
I
hi.
think we're just introducing ourselves.
Are we just introducing ourselves?
Yeah, please.
Okay. Okay, perfect. I'm Rachel, as you mentioned earlier. Obviously at Allegheny and initially from the Pittsburgh area, and currently pursuing a HEMONC fellowship.
Wow, that's great. And what about you, Abby?
Hi, I'm also from the Pittsburgh area, 4th year chief at Allegheny, and I'm also pursuing HEMONC.
We're similar.
Yeah.
Yeah, outstanding. And we have Melina and Alexis that are residents also in the program. Is that right?
Yes, we are the other 2 chiefs. We have a total of 4 chiefs.
Great.
So
Perfect. Yeah, can you guys introduce yourselves also?
yeah, absolutely. Hi everyone. My name is Melina. Thank you so much for having us. I am actually from Jacksonville, Florida originally, and then found my way up to Pittsburgh at residency at Allegheny, and then I am currently applying for an addiction medicine fellowship.
And Alexis?
Hi everyone, I'm Alexis. I'm also one of the chief residents here at AHN. Abby and I are actually sisters, so that's been a cool journey together. I'm also currently applying for fellowship, but I'm doing cardiology. Thanks for having us.
Yeah, we appreciated all you guys taking the time and participating today. And so now to the first thing that I would love if you, Dr. Gupta, can tell me a little bit, like for everybody, about the program and what you guys had in mind in the past couple of years, and what is the stage and what you guys doing at this point and so far.
absolutely. Hi, everybody. Thanks for having us. So just to start off, we do clinical reasoning morning report every Friday morning. I'm one of the moderators for that at our program, as is Dr. Reza, who's joined us now, Dr. Turk, who's on. We have a bunch of faculty that joined us today to see this too. And just seeing this group work through the case, both Zachariah and Jeffrey, what a tremendous job you did, truly exceptional. And we could present this case 5 times and learn 5 times as many things each time. There's so much to extract, and it was great to see others work through the case. And kudos to Vani. I think she did a remarkable job presenting. So clap for you, Vani.
Yeah.
It wasn't not an easy case to move through. So our program's in Pittsburgh. It's a large internal medicine program. We have over 100 residents. We follow an X+Y kind of schedule, which really lets us focus on clinic when it's clinic time and focus on the inpatient when it's it's time to be inpatient, and really get our heads on straight with the career arcs for everybody. We have a curriculum that works well as is, but we allow a lot of customization for our residents to pursue their interests. So whether that's through specialized tracks, there's 7 specialized tracks. One of the unique ones are inclusion health. So Dr. Venkat, who's on, is the director for that. So we have residents that can do things like street rounds, street medicine, substance use disorder experiences, working with refugee populations while they're already in training. We have a lifestyle medicine track, gender-based medicine track, research track. So really allow a lot of kind of customization of the educational experience. A couple things that are really unique for our program. There's a lot of hospitals that have gardens on their roof now, but I think we are the first residency program that started gardening. And so we took over our parking garage roof, and we have a garden there that's run by the residency program. And everything is organic, no pesticides, no herbicides. Melina's the garden chief this year, so that's a chief hat somebody wears. And everything we grow goes to our patients that are experiencing food insecurity. So that's a great place for residents to rotate and go, talk to vegetables and help them grow better, and then harvest them and get them to our patients. Those are just a few highlights, and I think we do a reasonable job kind of presenting things on our website of what the unique features of our program are. So if anyone's interested, you can check there. We're on Instagram, we're on Twitter, and you can also shoot us a message. Happy to answer any questions.
Yeah, that's lovely. Well, that's a wonderful introduction. And one thing that we like to ask here is what is one thing that you're most proud of in being part of the program and about the program?
I mean, there's so many things that I'm proud of, but at the end of the day, I think a program is as good as its trainees. And we're a program that, and I know there's a lot of international grads that are, on the call for this VMR, especially to have access to a case like this. My predecessor told me when I took over that, our program looks for the best talent anywhere in the world. Although we have 3 chiefs today that have kind of been raised in Pittsburgh, 1 from Florida, we have our residents come from all over the world. And so we're really proud of the diversity of our program and the people that we were able to recruit, and that's by design. So we pull US grads, osteopathic grads, and foreign graduates from all over the world, and we'll never change that. Regardless of what's happening with visas and anything else, we're always going to look for international graduates in our program. So.
Yeah, that's wonderful. And that's a super important thing in those days. And we want to thank you for giving all this introduction and sharing your ideas. And I'm also curious if Abby and Rachel and Melina and Alexis has any comments regards also like the same question, if there's anything that you guys think that is most meaningful for you guys, or that makes you happy about the program and so on.
Sure, yeah. I think I don't know. I think no matter where you go, like you're gonna get really great training. I think Allegheny's given us all really awesome training, and I feel very prepared for like the next steps. But I think the most special part about Allegheny Health Network was just, I mean, everybody always says on interviews the people, but I feel like we really do have a supportive learning environment from our admin staff to the attendings to the residents to the fellows. Like really everybody at the hospital is very supportive and really wants you to learn, and that's our goal. And that's why I feel like we've been really well prepared for whatever we decide to do in the future. So yeah.
Yeah, I would certainly echo that. I think for all of us being, 4th-year chiefs, now that we're kind of on the other side of the program, we see how much our program leadership cares and really cares about each resident individually. And so even though we're a large program, I feel that we just care so much about each resident and helping, them achieve their goals. And that's kind of, I think, not just with our program leadership, but even with our residents individually. A lot of our residents work on projects together, and everybody kind of wants each other to succeed. And I think that that's what makes the program really special.
That's lovely. Yep. And I just saw that Austin put a comment in the chat about like his transition to the program recently. And also, I don't know if you're able to unmute and share more about it.
Yes, after 6 years of Zoom, it's still hard to find the microphone button. But yes, I think it just speaks. So, I've been in Pittsburgh now for like 3 months, but already like here we are having the whole team come and interact. And I'm sort of known as like the CP solvers guy to do all like the nerdy clinical reasoning stuff, like already in the background of like a great culture, as Taz mentioned about the clinical reasoning Fridays, which is always like a very exciting time for me to join and get the extra rep in. But no, it really is just like an amazing culture and environment here. And it all comes down to, the people around you, as everyone had said, and it starts at the top. And I think everyone is really invested in you as, you're not only a person, most importantly, but also like what you want your career to be. And I haven't felt like any pressure for me to do any one particular thing. I can just be like my authentic self. And even when I was sort of getting recruited, so to speak, to come to Allegheny, like just they were excited to like see my experience with the clinical problem solvers and like view that as an asset, which is not true in many places that you go. And my interactions with like everyone so far has just been really incredible. So I can't speak to like the sort of amazing culture that's here. If I could invite all my CP solvers family members to help. Fortunately, I'm not the program director, so I don't have to make those decisions. But if I could, I would say everyone would thrive like really, really well here. And it's I have nothing but good things to say. And it all started just when I'll just share sort of like a personal story. My wife was and I met when I was a resident and I was at the University of Colorado and she was at another program in the area and was just having really not a good experience, not a good time. And she knew she wanted to pursue fellowship and the program that she was at had never matched a person into fellowship. And so I was like, hey, it might make sense to look into other programs and the idea of like second year spots. And it just so happened that Allegheny had a spot and met with Taz. And, fortunately for all of us together, he said yes. And here she is now. I guess we're 6 years later and she's a pulmonary critical care doctor. And here we are back in Pittsburgh. And if you asked me 7 years ago when we met if I'd be living in Pittsburgh, I'd say, what? No? Yeah, but we're loving it. And I think, again, just speaks to understanding the person and the individual. And no matter the circumstances they're at in life, he's just so skilled at recognizing people that are, I think we all like to, we're all here and sort of smart and bright, like at really big levels, because that's just the type of people that we are. We go into medicine, but like this has that unique ability to say, hey, this person is unique. And I know it's not traditional, but we can see it go well. And so I've just lived firsthand like the really wonderful parts about this program. So yeah, thanks for letting me blabber for a while.
Yeah, no, we thank you so much for like sharing all those ideas, and it's great to have all those perspectives and the general panorama, because it's hard to know when not like closely or being at the program per se. So if anybody in the room has any questions, please feel free or raise your hand. I'll give you 10 seconds and then we can move. Yeah, Simi, please go ahead.
First of all, thank you, Austin, for connecting us to such a wonderful program. And we're so happy to have you guys here and love the case and discussion. And I'm already sold on the garden part. It's just amazing having garden on the rooftop. But I'm excited to learn more. What is it like living in the area and how often do residents meet and what do you guys do to recharge after work?
I can take this one. So I, being from Florida, I came up to Pittsburgh for medical school, and honestly, we always say it's like a small, big city. So it has everything you need. There's always different cuisines. There's lots of things to do, from sporting events. If you want to be outdoors, maybe not so much in the winter, but if you're into theater, things like that. So there's a really good culture, a good art scene. So I think outside of that, and it's a safe city, we all live, I think between the Chiefs and I, we all live in separate areas, but everything feels like 10 minutes away. So to get to someone else, it's 10 minutes. Most of our residents, they either use public transportation or the hospitals. There's a lot of places close to the hospital to live, so close enough to walk, which is nice for a lot of people. But other than that, I love Pittsburgh. I always joke that there's something in the water because I actually met my husband up here, and then now we're like destined to stay here. So it's definitely a place to stay for sure.
Yeah, absolutely. Well, thank you so much. And yeah, I just thought also that if you guys feel comfortable about saying the like the special aspects to IMGs or like vacation time and so on.
I can talk a little bit about the IMG experience because I am an IMG. I did my residency, I did my medical school in India, and me and my partner both moved to Pittsburgh together after matching into AGH together. And it's such a wonderful program. And Pittsburgh is such a wonderful area. My mom is actually visiting me now, and we can get any single spice that she asked for, I can find in Pittsburgh. But at the same time, so it has really everything that you need. But at the same time, you can also get to the airport 1 hour before your flight and still make your flight, half an hour before your flight sometimes. But I think it's a really wonderful program too. It's so supportive. When I came to AGH, I hadn't used Epic before. And our program was, they understood the hardships with IMGs and the differences in the healthcare system, and they are nothing but supportive. As an intern, you get so much support, which now in second year, I look back at and I'm so appreciative of, and I want to make sure to give my interns the same level of support. It's such a wonderful culture. It's so welcoming. Everyone is more than happy to help you collaborate. I remember my first Epic training course. I looked at all of my AMG counterparts and I said, I have no idea what's going on. You guys, I'm so stressed out. And everybody held my hand every step of the way. Whether it was like even the medical students who had been rotating here for 2 years, or the attending, or my senior, or the chiefs, everybody is more than happy to help. And it's just such a wonderful program. And I wouldn't have been as happy or as good of a version of myself in any other program. So I really grown into the best version of myself, and I think the best doctor that I can be in this program. So I love my program.
That's wonderful. Yeah. And Taz and Richard, now do you guys have any final words that you want to share with us?
I think Austin kind of tagged us there to maybe comment a bit on what the program does to make the experience feel like what Vani experienced as a trainee. So I'll start with last night. So last night, we celebrated Diwali in the program, even though it was a little bit late. So to what Austin said about kind of bringing your authentic self to work and really recognizing the different cultures that we have. Diwali is probably one of our bigger parties that we do each year. And I know Vani was there with her mom. We try and get folks together in these kind of spaces. But a few of our residents, together with one of our APDs who oversees well-being, started a program, like essentially a Big Little program for international graduates. So we partner each incoming international grad with a current resident in the program. There's a survey asking about interests, maybe future career goals, where they want to live. Do you drive? Do you plan on driving? We consider that in terms of where we place people for their clinics. So if they're if they're not driving it or don't plan to have a license or a car, they're going to be closer to their main clinical site, which I think is really important. And then this Big Little program, they do such a great job pairing people. Like those relationships really flourish, and then you could see for the duration of residency can help navigate all the kind of minutia, how to get a social security number. And, these are the things that are really challenging. Or like Vani said, using an EHR, we run the EHR course. I think that's kind of different. So a lot of hospitals, they send you to like some Epic class and you're next to like a surgeon and a medical assistant and some new attending. But we've kind of our chiefs get credentialed to run Epic training, and we run it really focused on, this is a resident perspective, how to use the EHR, how to customize your EHR, which I think really helps folks that are coming from places that may not be dependent on that. And then I think we're also pretty flexible with vacation time. Like we understand that oftentimes, to travel to some places, like if you were going to go to kind of anywhere in the Middle East, North Africa, you're looking at like a 2-day kind of travel time, right? So trying to stack vacations with other time off, or a weekend plus a vacation together, so that, and string it together so you could have that amount of time to be home. And I think the chiefs are really incredibly accommodating. We send people back for weddings each year, and engagements, and traveling long distances takes some special accommodation. This year we even went and picked up a couple of our international grads from the airport because they were late because of all this chaos with the visa stuff. So we knew that their experience was going to be coming to Pittsburgh in the middle of the night when not everybody else is, it's different if you come in June when everyone's here. It's very different if you come in August and you're the only one and everyone's been onboarded already and they have their friend group. So I think one of our interns actually has Melina's comforter still because she brought a blanket to the airport because we knew she wouldn't have one. So I think those are some of the ways that we take care of people, especially international grads.
Wow, that's wonderful to hear. And so I want to thank you all for being here and taking the time and this beautiful Saturday to presenting the 16 case and saying a lot about the program, and that's a huge piece, and we've always been my data in the CPS. And well, thank you for everybody that contributed to the session to discuss some people doing teaching points. And I hope we can have you guys next year also. So thank you guys. Bye.
The opportunity.
Thank you.
Thank you for having us.